When a river breaches its banks or a heat wave blankets a city, the result is a mass casualty medical event. For decades, global public health infrastructure has relied on a reactive model. We wait for the floodwaters to recede or the heat to break, then treat the influx of patients who manage to reach the hospital doors. That model is mathematically collapsing. The frequency and intensity of climate-induced disruptions now exceed the surge capacity of our wards. Health systems cannot spawn infinite beds and staff to match these escalating extremes. Surviving this requires the anticipatory action framework. This approach moves away from recovery and towards the predictive, automated pre-deployment of medical resources based on forecasts before the first patient enters acute care. We must treat climate change as a deterministic engineering problem, building a proactive defense rather than waiting for hospital beds to fill. Global healthcare is still largely fighting the last century's war, structurally focused on vaccine-preventable infectious diseases. Data shows a significant anomaly. 71% of global mortality is now driven by non-communicable diseases, or NCDs, which are heavily aggravated by environmental factors. Extreme heat and particulate pollution act as systemic stress multipliers within the human body, altering blood regulation and forcing the cardiovascular system into a state of constant overdrive. These stressors directly precipitate acute crises: cardiovascular failure, chronic renal disease, and premature deliveries, the latter of which are driven heavily by air pollution in lower-income regions. Ending fossil fuel dependence could prevent 1.6 million premature deaths annually simply by cutting this systemic pollution. Fossil fuel pollution serves as the primary vector for a modern, untracked NCB pandemic. The operational core of anticipatory action involves deploying prearranged funds and protocols automatically upon early warning signals before disaster strikes. This requires two distinct data streams. The first involves hazard-driven inputs, relying on meteorological forecasts and strict temperature or humidity thresholds. The second stream utilizes disease-driven inputs, relying on epidemiological models and clinical case thresholds. Structural data silos currently prevent this model from working globally. Health ministries often cannot access the weather data hoarded by the aviation or transport sectors. The bridge across this gap is a computational metric called epimodulation. Epimodulation integrates immunological dynamics, the way diseases behave within a population, directly into meteorological forecasts. By feeding these dynamics into weather models, epimodulation increases outbreak prediction accuracy by up to 55%, transforming weather reports into medical intelligence. Predictive modeling is only useful if it triggers localized deployment before a crisis peaks. Consider a waterborne disease scenario, such as a predictable cholera outbreak following a projected flood. Health teams utilize Case Area Targeted Intervention, or CATI. CATI is a rapid response strategy that focuses preventative measures within a specific geographic radius of a predicted threat. Based on flood projections, CATI teams preemptively combine oral vaccination, localized water chlorination, and hydration distribution, rather than waiting for case counts to rise. We see a similar strategy for vector-borne diseases. Rising heat and rainfall push diseases like malaria and dengue into entirely new geographic latitudes. By using genomic sequencing to identify drug-resistant variants, health systems can trigger localized larviciding before vector populations surge. The anticipatory action framework shifts public health from a system that reacts to casualties into one that tactically prevents them. Predictive models will still fail if the intelligence remains trapped at the national or tertiary hospital level. The Health National Adaptation Plan, or HNAP, provides the structural framework to decentralize this intelligence. An HNAP is a country-driven plan that ensures health systems can protect vulnerable populations during climate impacts. This framework pushes climate-informed surveillance down to the primary care and village administrative levels. This decentralization empowers local village action plans to act on climate intelligence independently, utilizing local funding mechanisms. It allows for the integration of NCD screening, like mobile blood pressure and blood sugar monitoring, directly into standard disaster relief protocols at the community level. An HNAP ensures that sophisticated predictive data actively protects marginalized populations at the very edge of the health system. The technological blueprints for climate-resilient healthcare, epimodulation, CATI, and HNAPs, are already proven to work. Global implementation is blocked by a macroeconomic paradox. a systemic failure in how capital is allocated. The global economy currently spends $7 trillion annually subsidizing fossil fuels. Nations are funding the environmental hazard that is systematically destroying their own public health infrastructure. In some regions, fossil fuel subsidy bills eclipse the entire national health and education budgets combined. The barrier to climate adaptation is not a lack of scientific knowledge, but a deliberate misallocation of global capital. Every fraction of a degree rise and every delayed policy decision translates directly into measurable human suffering and lost labor hours. Health systems must lead global climate adaptation efforts, as they are the first to feel the shock of a disaster and the last to recover. Shifting funds from reactive emergency response to foundational, predictive public health investments requires sustained political commitment. The climate crisis manifests as a physiological pandemic that is actively occurring right within our own bodies. To survive this era, we must stop subsidizing the sickness and start engineering the cure through proactive, climate-integrated health systems.